Prof, a very good afternoon to you. So how much attention are you as an advisory committee paying to these latest findings?
Yes, very good afternoon to you and all of the viewers. So we are learning about new presentations and new pathology caused by this virus on a regular basis, almost at least I would say 1 or 2 a week. To give you some idea, if you spoke to me 10 days ago and asked me, does this virus cause diabetes? I would have said no. Well, the answer now is yes. This virus can attack and kill the insulin-making cells in your pancreas, and it can cause people to become diabetic. So we are learning new things all the time. In this particular instance, we have known that this virus leads to an inflammatory response in the small vessels. In fact, in the toes, you see it most clearly, where you get these red blotches because the vessels start bleeding because of this inflammation. It's a similar thing that we see in the head. That in the brain, there's a swelling that occurs because the vessels start enlarging due to the inflammation, and then they start bleeding, and so you get strokes. This has been described, and it, in fact, first came to our attention in adolescence, and now we actually are identifying it as much more common than we originally thought. This is a new disease. We are learning new things all the time.
But the implications then, one has to wonder what the implications are for treatment if we are almost weekly or bi-weekly discovering a new complication as a result of COVID-19, Prof?
Yeah, so one of the interesting things about it is that we know that about, say, not know, but we think that somewhere around half of the patients, people who get infected, have no symptoms. But those who have symptoms, a small proportion, somewhere between 20-25%, will have a need for medical care. And of those, a proportion will get quite severely ill. Now, what we understand is that those individuals that get severely ill, the damage is not due to the virus as much as it is to the immune response. It's what is called an immune overreaction. There's something called a cytokine storm. Cytokines are signals. It's like the general saying, I want you to mobilize the Army, the Navy, the Air Force, everybody, we need you. So what happens, all these immune cells come and you get inflammation. We now have seen the results of the dexamethasone study, where dexamethasone, which we've known for many years, it's a long-standing drug, actually works quite well in suppressing this inflammation. So this particular presentation in the brain, with the swelling, with the coagulopathy, this bleeding disorder, with the strokes, dexamethasone may turn out to be something that would suppress some of that inflammation and decrease the consequences of this disease.
And Prof, the frightening thing about the neurological research that we're hearing now is that there's no clear evidence at this stage of whether the damage that has been seen in these 40 patients tested in the UK will be permanent. So we're likely to have to wait years, possibly, before we know?
We're just learning so much about the sequelae. If you ask me in March, would you have patients with long-term problems trying to breathe after getting COVID? I would say, why? Once you've cleared this virus, you're done. Actually, that's far from the truth. We now are seeing many patients, once recovered, they actually have long-term sequelae. They have long-term consequences on their lung function. And we're only just beginning to understand that because, we've only known this disease for such a short time. I think with the neurological effects, because much of it is immune-mediated, I would think, and I'm only speculating here, that most of those would be reversible. What would be a challenge would be where there's been a break in the vessels from the inflammation and you get a bit of a stroke. what we call, when there's a little bit of bleeding and you get hypoxia and you get a bit of death of some of the cells. That takes long to recover. That we will expect people to take a few years to recover. And they will. Stroke victims, often the damaged areas, they learn to compensate and they will do better. It won't be 100%, but they should have less functional challenges as we go along.
And there are people, sadly, in the world who do die of strokes. Does this, do you expect, then complicate that debate we've been having over the past few months about the classification of deaths, a COVID-19 death or just someone who had a stroke and died and happened to have been COVID positive?
Yeah, we seem to be challenged in this respect in multiple ways because many of the patients with COVID don't actually die of COVID. They die of other problems. And so the primary cause of death is some other disease, acute respiratory distress or cardiovascular or something like that. But the contributory cause is listed as COVID because they tested positive and they had the signs and symptoms of COVID. And so they are counted as a COVID death. They may not have actually died from COVID. And so we get a bit of overcounting, but we also get a bit of undercounting because we're not always able to identify everybody who's died of COVID. So it's a bit of a match. And this is not unique to us, of course. Every country has this challenge. In the particular instance here, because of the way in which the little vessels get inflamed, we're not likely to see many deaths. We're not likely to see, a big stroke where somebody, one whole side of their body can't move, because that generally happens when you've got large vessel disease. I don't know yet, and it's still early days, as to how often you see large vessel disease, but at this stage, based on what we know from the inflammatory response, it's likely to be a much more minor stroke, and so we're not likely to see many deaths as a result.
And of course, as I was saying earlier, Prof, we're basing our conversation this afternoon on a study from the UK conducted on 40 patients who did show some signs of abnormal brain activity as a result, possibly, of COVID-19. Is 40 a large enough sample to go on in looking for everything that we've highlighted just now?
We've got to start somewhere, and 40 is a good start. Yesterday's New England Journal of Medicine published a paper of 143 adolescents in the US with a new disease from COVID called multi-system inflammatory response, and it occurs principally in children or in adolescents, and it's called MIS-C, M-I-S-C. And it looks a bit like Kawasaki disease. It's a bit of a generalized disease, affects most parts of the body. But, every one of these new conditions that we're learning about with COVID, we're going to have to start small and identify the first few cases. And then the word gets out, and then everyone starts looking for them. And as we do that, we will start finding more. And then we'll be able to describe what kinds of patients are most impacted. We get a better understanding of what this self-cure rate is, and we get some better understanding of whether it's increasing deaths or not.
Professor Salim Abdul Karim, epidemiologist and chairperson of the COVID-19 Ministerial Advisory Committee. Always good to speak to you, sir.